So, as you know, I finished my post graduation in 1994. And even when I was a postgraduate, I always used to wonder why we have to do complete dentures for our patients. I never liked complete dentures, not because it doesn't help patients, but there are so many better ways of helping our patients, especially in a country like ours. So if I found this paper from 2021, and it says that the overall prevalence of complete tooth mortality, that means loss of all teeth, is 10.7% of our population. Our population is now 1.4 or 1.5 billion. So you can imagine you have over 100 million, totally edentulous patients. And the partially edentulous patients are 58.8%. Of course, the rural population, is more than the urban population, which is expected. And my thought always goes back is why can't we preserve some teeth and make overdentures for these patients? And I'll tell you why. So the first question is, what is an overdenture? According to the glossary of prosthodontic terms, which is the Bible, an overdenture is a removable, partial, or complete process which is supported by one or more residual natural teeth, roots, or dental implants. Now, what are the key factors in overdentures, and especially tooth retained overdentures? Um, so, of course, both tooth retained and implant retained will help to preserve the alveolar bone, which is surrounding the implants or the natural teeth. And actually, when we have natural teeth, the one advantage that we have, which we don't have with implants, is proprioception, because your periodontal proprioceptors are still present and they provide sensory feedback. And of course, they improve the support and stability of the denture. We all know that mandibular dentures give a lot more trouble than maxillary, because you don't have as much surface area, and also the tongue is present there. And the final thing is that if you have an tooth supported overdenture, even if let's say your abutments fracture after 5 years, you can still convert them to a complete denture, or better still, go in and place a couple of implants like we have here. You can place two implants and give a really wonderful complete denture to the patient. Here you can see an attachment that I very frequently use, and I will explain a little more about that. So, if you come to the types of overdentures that are there, so you have either tooth retained overdentures, or you have, and I've written very carefully, tooth retained. They only provide retention, they do not provide support as much. Or you have implant retained overdentures, both maxillary and mandibular. And when you have implant retained overdentures, you can have either immediate loading or conventional loading. And you also have implant retained removable dentures, especially cast partial dentures, which we will not be discussing today. So if you think of tooth retained overdentures, then there are many advantages. So they improve both retention and stability, especially in the mandibular denture. The support is provided by the mucosa in the posterior part of uh, uh, the lower jaw. Okay, so support comes from the mucosa. That's why it's very important that dentures are made well. They are cost effective, because all you have to do is either maintain two canines or two premolars, or even one premolar, one canine. First premolar. We want single rooted teeth. We do not prefer to have double rooted teeth. Um, and most importantly, of course, you have proprioception and you have reduced alveolar bone loss or bone desorption. And of course, there are many types of attachments, and I'm talking about only about tooth retained overdentures here. Okay, you have bar and clip, which I've probably never done for, either I haven't done one for a very long time, because now the attachments are so good that you really don't need to splint them anymore. And I'll show you data to back that up. So bar and clip, I don't use. The last one, I did use it for one maxillofacial patient, but those are very, very different circumstances. Or you can have an ball and an O-ring attachment like you have here. These are intraradicular attachments, and I'll show you what I mean. And you can also have magnetic attachments. I have no experience with magnets, especially intraorally. Extraorally, I do sometimes for auricular processes. Intraorally, I just have never used them. So, this is one case where I want to show you can see there are two canine teeth. Even though you have bone loss here, if you have 50% of bone present, you can still utilize these teeth. We have also utilized teeth which have got up to grade 2 mobility, because once you reduce the crown root ratio, you're going to cut these down. You will then improve the mobility of these teeth. And this is a attachment system called the Ceka preciline. Again, whatever attachment systems or implants that I show, I have no financial commitment with any of them. It's just that I use those, I like those, I use them. And this is how you go about doing the about placing the attachment. So you have the first drill, pilot drill, then you make a receptacle for this part of the attachment that goes in and sits. You make the final depth and width, and finally you will cement the attachment down. And this is a short video which explains that, so you can just have a look. So you go ahead and you press the teeth down. Then you measure the height. You need to be, the height needs to be correct. The first drill goes in. Again, you need to keep pulling this down. Then the receptacle is made here, as you can see. And in all of these, you need to keep cooling it down because it generates heat. That's the final drill that goes in. That's the attachment which is tried on. And finally, we cement them either with resin cement or with RMGI, one of the two. Yeah. So that's how you, and I normally don't use them on the same day. I allow them to set completely and call the patient back and connect the dentures. These are the different types of nylon springs that are available. Retention springs, you can see the white is the lowest, yellow is what I normally use, red I have never used. They are too retentive. So this is the same patient. So the patient came to us with all of these root stumps. In the maxilla, we decided we needed to extract all of them. In the mandible, we only preserved both the canines because they were the ones that we could. You can see the one on the left, you have 50% of the bone, so you can still preserve that. Go ahead and get root canals done. And then, like I showed the procedure in the previous slide, you go ahead and place the attachments. Now, if you can see here, I have gone outside the canal. The problem is when you have freestanding canines or premolars, they tend to supraerupt and they tend to diverge. So, for these ball attachments, you need to have the attachments as parallel as possible. If you diverge them too much, they will not work. The clips will keep wearing out. So there is a possibility of, a perforation here, but you need to be careful about that. So you can see here, this is how it was, when the patient came back to get his complete dentures done. And this is after 5 years or 4 years. So you can see maintenance is key. You need to smoothen all these areas down so that the patient can keep it healthy. Of course, caries can happen over here. So maintenance is very key from the patient. You can see we have full extended dentures right up to the retromolar pad. Like I said, the support comes from the tissue. Only the retention comes from the implants. If you take retention and support from these, you will end up causing problems here, and you can cause fractures of the tooth. The tooth will crack and fracture. Now, this case I have called as tooth and teeth separated. Why have I called that? Because we have one molar here which we can use. Why do we need to go and extract that? As dentists, we need to stop thinking about extracting teeth. We need to try and preserve them. In the maxilla, even though we have not utilized and placed attachments there, we have still saved the two canals, done root canals, put a filling and closed it. At some point, if we want to use them, we can always go in and use them. Why do we go ahead and extract these teeth unnecessarily? Same thing. Again, we have made that. So we have made a rest seat on this, and we can put a clasp on this tooth, And we can also utilize these two for retention. So this area actually becomes tooth and tissue supported, and this area is tissue supported. So I take all my primary impressions with alginate. Then we make special trays. We make our own special trays with the light curing material in the clinic. I take all my final impressions with VPS medium body and light body if available, or you can take it completely with the VPS medium body. This is the denture, the cast partial that has been fabricated. You can see you have a rest and you have a clasp, which will help you in retention also. This is the denture, and this is after the attachments have to be picked up in the mouth. Now, in all of these cases, I pick up the attachments in the mouth. Why? Because the RealF plays a part. Implant companies and these attachment companies do provide analogs, but when you are doing it on a stone model, or even if you are digitally doing it, you will not be able to incorporate that real F in that. So that is a very important thing. So the attachments must be picked up in the mouth, and you must do it properly, or you can get acrylic locked in there. So that is a very important step. And this is the final processes you can see. So he has a single complete denture on the upper, and an overdenture. Actually, this is a cast partial with two overdenture attachments and one abutment tube. Now, this was supposed to be only mandibular, but I thought I would just show a maxillary case. This is the kind of dentistry that really irks me. Why would we do something like this for a patient? You have couple of few abutments here. You're making such a huge cantilever for the patient. This is absolutely unjustified in doing. And the problem is, this patient is 90 years old by the time she came to me. And at that age, I did not want to go in and do anything here. But, we as dentists need to think, the kind of work we are putting out for our patients. And she was complaining about her upper denture being unstable. So even though there were two canines, which were not in the best of shape, but we got crown lengthening done for her, we got root canals done for her, and we went in and placed two attachments. So would I do this for all patients? Absolutely not. This would not be my first choice in the maxilla, because normally in the maxilla, your denture, if made well, stays well. But this can be an option. You can have two maxillary teeth, two maxillary canines in the maxilla, and you can give this for patients who are, I would look at them only after about 75, 80 years of age. Otherwise, I would give different options. And of course, over a period of time, this extraction also was done on the day of delivery. There was a root stump there. And later on, we will, if required, we will just go and reline this with something like rebase, which I will show you. Now, of course, just like everything else, there are problems with tooth retained overdentures. So you need to have either canines or first premolars. And as I had mentioned before, these teeth supraerupt, if it is a long-standing edentulous case, and that leads to reduction in the root length. So if you have up to 50% of the root, you can still go ahead and place a overdenture. Caries is a big problem if the patient does not maintain, if the patient does not have manual dexterity, that can become a problem. And there can be fractures of both the attachments and fracture of the root. So these are, things that need to be noted. What about implant retained overdentures? So implant retained overdentures, you can again do them for either the maxilla or the mandible. I mainly do them for the mandible, very rarely for the maxilla. And you can do either immediate loading or you can do conventional loading. So these are the two protocols that we follow. Now, if there are any prosthodontists, they would know who Charles Goodacre is. Charles Goodacre is the very well-known prosthodontist based out of the US, and he wrote this very amazing article in the Saudi Dental Journal on the benefits of implants. And it's a very short article, just 2 pages, but it has a lot of information. So he said that in his career of spanning almost 40 years, the paradigm shift that he saw was the use of dental implants. So, and when we as dentists think of implants, we only think of fixed. I don't know why we do that. Unless we as dentists are convinced that removable prostheses work, we will never be able to convince our patients. Patients are very smart; they can see through you. So that is something that we need to get convinced about. And I hope that after today's lecture, that you will start thinking about this method of rehabilitating patients. And he said the main benefit comes when treating patients who have conventional complete dentures. So we all know the term denture cripple. Patient wears a denture for 10, 15 years. Mandibular ridge is completely resolved in some cases, and the complete dentures just don't stay. So in patients like that, we can go in and help. Not all of them. They need to have a minimum amount of ridge height and width. And we'll come to that. So patients can now have implants that provide support and retention for their dentures. Depending on the number of implants that you use, it will either retain the denture or it will support the denture. And I will show you some situations. So, what are the psychological benefits? So, you have improved appearance, because now when we make complete dentures, we always like to place the teeth, especially the lowers, in the neutral zone. So, that may not be in the most aesthetic area. So, these help to, since they help to retain, they will improve the appearance. You get better patient satisfaction and, more importantly, better quality of life. And of course, like I said, they can be placed in their optimal aesthetic positions without causing denture instability. So the reason why we place it in the neutral zone is because of the stability of the mandibular denture. And all of us would know this Atwood's classification for residual ridge resorption. So how does it happen? You have a pre-extraction ridge like this. Then you have a post-extraction. Then you have something known as a high well-rounded, when the denture will normally sit well. Then you go to a knife edge. Again, the patient will slowly start having problems here. You go to low well-rounded and you go to depressed. When the patient has a depressed ridge, the complete denture will just not stay. So it is better to intervene somewhere. I mean, right at the beginning would be the best, and go in and at least place 2 implants for these patients who come to you completely edentulous. If they come to you partially edentulous, then try to find some teeth. And normally the canines will always be there. They are the last teeth to be removed. So, what are the functional benefits? Of course, you have improved biting force, increased biting force, and therefore patients can eat better quality of food, and they can eat better food. They have better food choices, especially when the denture is loose. Their food habits become really poor, and that affects their GI and their whole system. And the anatomic benefits are, once we lose all our teeth, to me, it is we are putting the patient to a, it's like a no return situation. It will only keep deteriorating. So when you remove this and give a complete denture, it results in continued gradual bone loss. The maximum occurs in the first 6 months, but it continues throughout life. And in some it is more, and in some it is less. And patients who are given implant overdentures experience less bone loss, especially around the area where so that the implants, the nature thinks that those are teeth, and they mimic and they save some of the bone around those areas. So they experience less bone loss as compared to your complete denture patients. And in complete denture patients, you have atrophy of muscles around the mouth, because the stability of the implant overdentures is greater. You will have greater muscle activity, and therefore the atrophy of the muscle will be reduced. So these are all huge improvements for the patient. So, what about implant retained immediate? Now, I said you have immediate mandibular overdentures and you have conventional mandibular overdentures. So, these implant immediate mandibular overdentures are now considered the standard of care in the treatment of mandibular edentulism. In the West, they prefer to do fixed. Yes, we can do fixed, but for a majority of our patients, finance is a problem. The bone quality, the number of implants that we can put becomes a problem. So, in our situation, I feel that overdentures are probably a better option. Now, what does the immediate loading mean? Immediate loading means that the prosthesis is placed within 48 hours of implant surgery and it is functionally in occlusal contact with the opposing dentition. If it is not functionally in contact with the opposing dentition, it is not a immediate loading. And they have also found that mandibular overdentures using locator type of attachments, and I will show you what they are, showed higher stability and less bone and soft tissue loss after 12 months. So you have ball attachments, okay, and there are various advantages and disadvantages. When I'm doing implants, I no longer use any of these. I don't use ball attachments. I don't use bar attachments. Well, bar very rarely, but those are in maxillofacial cases. Mainly, I use locator-based attachments, and the reason I do that is they can self-align themselves up to it's always not possible to get them absolutely parallel. So 20 degrees on either side is the maximum here. Narrow interarch spaces. Okay. The only disadvantage is that you have to change these nylon components. So this is a locator based attachment here, and I'll be explaining about that. So this is the attachment which goes into the implant, and this nylon spring goes into the metal housing here. These are the bar type of attachments which we used to use earlier. We don't anymore, and magnets, of course, I don't use them at all. So this is a case that I will be showing you. Again, similar kind of situation. These two abutment teeth are supporting these huge processes. We should not be doing this kind of dentistry for our patients. And she's actually, if you see, got some chewing gum here to help with that. Very unfortunate. And my colleague, I work with Dr. Anjan Shah, and this is an immediate case. The advantage here, that one advantage of having this here was that the vertical was maintained. So when you are doing immediate cases, you need to take impressions of these, get the correct vertical, send it to your lab. They must be able to score everything and make a denture for you. So that you need an excellent lab to work with. Same thing, the dentures, the implants are placed along with the attachments. This is where the attachments are picked up, and this is the prosthesis in position. And this is 1 week after the prosthesis was given. So I'm just going to show you a small video showing part of the surgery and also the prosthetics. So you can see here, Dr. Anjan is contouring the bone. Then he's going ahead and placing his implants. He plans these on a software, but we don't use guides. He prefers not to use guides. So this is a tissue level implant. You can see the polished collar here, 3 millimeters. This is a Straumann tissue level implant, which we use very commonly for immediate loading cases. And this is the implant carrier. And you can see that, they are placed in a good position. So these are the locator attachments going on. And this is the before connection. Now, this material is amazing. This is very ordinary, VPS light body from Zermac. I get it in tubes. Ideally, you are supposed to use fit check, but fit check is very expensive. So we identify where the area is. Usually, you have to perforate the denture, which you do here. You just put some dam, and that ring helps that acrylic will not go in and get locked. If acrylic gets locked there, you are in big trouble because you have to cut the whole thing out. This is 40 micron Bosch articulating paper which we use to check. This is after the pickup, and this is after polishing everything. These are the implants. So these implants, we try to give at least 15 millimeter length implants for these patients. Now, this is a prosthetic video. After I picked it up, I'm again going to go back it and check and see if any areas are overextended. This is a very important step which we should do. So again, we go in with the same material. The only disadvantage of that material, it takes about 3 minutes to set, unlike quick check, which sets in 1 minute. You take it out. See, you can see a huge area. This would have, if this patient comes back in a couple of days, you'll have a huge ulcer over there. So this is a very, very important step. It also shows us that the denture is seating properly. We do not want anterior posterior rock in the denture. These are the. This is a case of conventional loading where we wait for 3 months. After a week, after the implants are placed, we reline with soft liner. I use GC soft, and then we go in again, take alginate primary impression, and if you can see, we are keeping the attachments. This is a peak attachment. We now prefer metal attachments to peak attachments. So we are keeping that there and then taking the impression so that the technician will keep adequate space. If that is not done, that will become a weak area and the denture can fracture there. So this is normally we keep a metal framework inside. In this lady, we decided not to, but she's doing fine. So that's okay. This is the latest case that we have done. Again, primary impression was taken, special tray was made. So you can see the housings going over. Need a good, well extended tray. Border mold where necessary. I prefer to use green stick. I'm not a fan of putty border molding. So yeah, again, follow the normal routine. Adhesive is very, very important. Without that, your impression will distort. Put light body around if you have, or just go with regular body. No problem. Medium body. I use Aquasil. I'm very happy with that material. I've been using it for a number of years. Again, border mold. And you can see you get excellent retention, and that's not because of the attachment. So you are using conventional techniques as well. These are well extended impressions. You need to have them well extended. This is mandibular. This is a maxillary. Same technique, conventional technique. Jaw relations. Again, we are using. Sometimes I use Aluvax. Sometimes I use Imprint from 3M. Again, all of these materials I have no financial obligation. I just like them, so I use them. And this is the trial. You need an excellent technician to help you with good settings and good arrangements. This is the final. What we do is, if you're getting a metal framework inside, we do that trial. Then we ask the lab to make the framework, and then again do a trial with that, because otherwise it can vary. So you can see here the receptacle that the lab has made, and this is after picking up the denture in the mouth. So this is what the patient has got now. Again, same thing. Patient came to us with 2 sets of dentures. He said he's not able to use the mandibular denture. So you can see we have put long implants inside. They're all usually around 13 to 15 millimeters in length. And you can see that the process is in position. Now, these are some of the attachment systems that are available. So these are known as mini implants. Mini implants are implants which are less than 3 millimeters in diameter. And this was made by a company called Imtech, which no longer exists now. And you can see the metal housings are here. So you can put 4 here in the mandible and they are immediately loaded. And so you keep the denture ready and do. Of course, this company no longer exists, so this is defunct. These are the locator attachments that I was talking to you about. And I have a video which will explain this better. So you have, I'm sorry, I just have a cold. So this is known as the abutment, which goes into the implant or the matrix, and the metal part that you see is called the housing or the matrix. And you have different color coded nylon attachments, springs that go into this, and the retention varies according to that. So this is just a short video. These are mini implants which are less than 3 millimeters in diameter, and this is a one piece implant with a ball attachment. And we normally put 4 in the lower and 6, I think, in the upper. And these are the housing which are there. And these can be immediately loaded. Of course, we don't use these anymore. And this company itself has shut down. So this was one way of doing an overdenture. Then these are the locator-based attachments. So we have either a 3.5 or a 4.1 implant with 2 locators, and 2 are minimum that are required. If the denture needs to be made more stable, then 2 more implants with locators can be added. This is known as the matrix or the attachment, and this is the matrix or the housing. So you have a metal housing with different types of these springs, springs that are there. Each is color coded and the retention varies in that. So this is how it goes over. And this is another locator based type of attachment. These are from the Straumann company. They are called Novalock. This is how it is fixed on. You take it out like that. You can just screw it back on this. And again, we have just duplicated these, and these are again the matrix with the housing in that. And you can see that it goes on nicely. So, we have been talking about overdentures, and let me go back one slide. Yeah. In my practice, I found that having models to explain to patients is very important. Yes, there is an investment to be made, but it's worth that investment, because when patients actually see what there is, it helps. And I have an excellent technician. So the Straumann models that I showed you were made especially for this lecture. And I would urge you, if you're going in for this, to try and get one of these sets and actually show the patient how it works. Now, I think some of you will know that I work a lot with cancer patients, with tumor patients, and overdentures are not used only in regular patients. So I just want to quickly just show you one case, where we use it. So you can see here, patient comes in. This was a benign tumor. We scan the patient. I don't use scans much, but yeah, in this case, a scan was useful. And you can see where the tumor is. These are the cutting guides, 3D printed cutting guides. We can do mirror image and we go back to what we want. We can position implants where we want. And we use this bone, the fibula bone, most frequently in the mandible. So that's why we want the implant to come. So you can see again you have a cutting guide for the fibula and a drilling guide for the implant. So this is how the fibula is positioned. And 4 months later, you can see this is skin from the leg. And of course, it is impossible to rehabilitate a patient, who has this much of tissue in the mouth. So then we do a procedure called DGER, where we try to convert the tissue into alveolar mucosa. So again, we had one implant at surgery. We place one more implant. We take an impression at this stage, get a plate made, If the tissue is not as thick, I do place some teeth on it, and we go in, and actually we split the tissue in the middle, and we tuck it here and tuck in the lingual, and this is actually bare fibula bone, and we pick up the attachment. The reason we have only picked up one is because this one, the torque was less than 30 MCM. So this is the material. This is a magic material. It's called Rebase 2 from Tokoyama, and it's a polyethyl methacrylate. That's what I use for all my cases, even in the regular cases. So this was after surgery with one implant, and this was at after second stage with the second implant placed. And this is how the tissue starts healing. And it's magical how just a plate can guide the tissue in healing. So you can see here, June 30th, patient comes back after a week. Then he comes back on July 12th. Unfortunately, the implant was not, the attachment was not seating down. So you can see a lot of extra tissue there. So we correct the denture. My associate, Dr. Ritika, spent a lot of time doing this. And you can see the same material, we buy bucket loads of that material to help seat the denture. Patient comes back on August 2nd. You can see it's starting to heal up beautifully. Again, adjust. Again, patient comes back on 9th, and you can see that the anterior, this portion is healed well. Again, correct. So here again, the healing is progressing. Here we ask the patient to massage, and you can see in less than 2 weeks how the tissue has become. And finally, on September 27th, we went ahead and, since the tissue was almost settled, we went ahead and took a preliminary impression. So this is how I make preliminary impressions. I place wax in them. You need alginate adhesive here. Unfortunately, we don't get it in our country, so you'll have to ask somebody to bring. Take a primary impression, and then you can see how beautifully it has healed on October 2nd. We do a trial for the patient, and on October 11th, we actually deliver it. So within 3.5 months, we have taken him from here to here. So that is what we want to do for our patients. So now, what are the conclusions with regards to mandibular overdentures? So mandibular overdentures, as we know, lack stability and retention as compared to the maxillary due to reduced surface area. And implant overdentures are a predictable option, improve the quality of life of these patients. So although they can be immediately loaded, but most people do the conventional loading protocol. What I would advise is at least for the first 3 or 4, do the conventional. Learn the technique first and then go in and do the immediate. And also work, either you do everything yourself or work with a surgeon who understands the prosthetics, because prosthetics is vital in these cases. And 2 implants are sufficient for retention and stability. So overdentures must have a passive fit. Okay, so you need to do your checking. You need to keep checking. Support comes from the posterior mucosa. And occlusal overload due to excessive lateral stresses. So you don't want much of lateral stresses on these, can lead to marginal bone loss and implant failure. Implant failure and overdenture fracture. So you can get breakages of these dentures. So I would like to thank you for your kind attention. And it is my, other than maxillofacial prosthetics, this is one subject that I'm very passionate about. And I'm hoping that more and more general dentists also get into this and help the huge population who are struggling in our country. Um, I'm very fortunate to, to have some great people to work with. This is my clinic, Oracare Dental Clinic in Bangalore, in Frasertown. This is Dr. Ritika, who's also a prosthodontist who works with me, and these are both my assistants. I've been associated with Narayana for over 15 years, and I'm very fortunate to be in that department. This is Dr. Vijay, who is the HOD, and this is Dr. Trupti, a oral maxillofacial surgeon whom I work with very closely. This is our center at Aster CMI, and this is Dr. Annie John, who is also a prosthodontist who works with me, and this is Dr. Anjan Shah, who we do a lot of implantology together. So if you want to get in touch with me, the best way would be through my Instagram channel, that is at Dr. PC Jacob. This is my website. And also I'm on LinkedIn, that is P space C space Jacob. I'm there. And I would urge you to, the next time you want to extract a tooth, to, rethink whether you actually want to do that, and to try and save as many teeth as possible. Or if they are edentulous, then to consider placing two implants and doing an overdenture. Thank you very much.